Respiratory presentation. Oh, just started recording for a little session on peds respiratory presentation. So it is quite a vast topic, as I'm sure you know. Respiratory presentations are a major part of pediatric medicine, both in hospital and in GP. So for this particular presentation, I've tried to cover 5 key areas really, and what's relevant for medical students. You know, we could go into all sorts of crazy details, but you probably don't need it. And let's stick to what's really relevant for you for exams and what you'll see, you know, when you start working as junior doctors, first of all. So the 5 key presentations we're going to cover today, we're going to be talking about wheezing, stridor, cough, breathlessness, a teeny bit about snoring, and we'll mostly be talking about pediatrics rather than neonates, but I will touch on what's relevant for children who are quite young or just born, who also have some, degree of respiratory distress or respiratory issues. And we'll be talking about the exams classics really. And I'll keep an eye out for this helpful exclamation sign for things that you really shouldn't miss, both in your exams, but also in real life if you ever encounter these children doing a pediatric job, anything like that. And I've also got, I think I've made it disappeared, but with the questions you will get ranges for, pediatric ranges for normal observation, so don't worry about that. So we'll start right away with question 1. I'll give you a minute just to read this out. And then we'll flip it around. All right, let's see what you guys think. Very good. Yes. So looks like the room is a bit divided, but the majority of you picked the right answer, which is D. So let's have a look. So we've got a 3-year-old child who looks like has had a few episodes of wheezing. Sounds like these are related to him having a cold, so upper respiratory tract infection. And this is not the first time it's happened, but the child also has eczema, which starts making us think about, could there be anything more to this child's wheezing? However, he is 3. All these episodes have only happened when he's had a cold, so he's been symptoms-free in between, and current guidelines from NICE are that we try these children on a bit of salbutamol. And the reason, so first of all, we wouldn't start steroids in a child with, no suspicion of asthma. He's a bit too young to do a peak flow reading. He's only 3. We usually do them in children above 5. Same with spirometry, not appropriate for an investigation for a 3-year-old child. And in terms of advising dad that the son will not need medical management, that's not quite right. So, he's had multiple episodes of wheezing, and we will treat this child with salbutamol. So let's go back to our basics and respiratory examination. So like any examination in pediatrics, these are very opportunistic, so you always try and examine the child when they're not crying or screaming. And the best thing you can do is minimal handling, because that does tend to upset children, especially if they're already in respiratory distress. That's a good one to avoid. But the top 3 things that we need to assess when we're examining a child for respiratory are effort. So first of all, we're looking at what's the respiratory rate. Are there any signs of respiratory distress? How about the efficacy of their breathing? What's their air entry? Is a good chest expansion? And then we can also take a look at the oxygen saturations. And then what are the effects of this child's, respiratory distress or any respiratory issues? So we then look at the heart rate, what's the skin color, what's the child's mental status. So it's worth keeping these in mind. And remember, red flags when assessing poorly children. There's very clear guidelines from NICE, especially when you look at the guidelines on fever in under 5-year-olds. They really love looking at the traffic light system, which I will bring up in a second. But the main things we're looking at are feeding. Is there any distress, cyanosis, and drowsiness? So when it comes to respiratory distress, the younger the child, obviously slightly different the signs. Things that you'll be looking out for are an increase in the respiratory rate, an increase in the heart rate, especially in younger children. Is there any nose flaring and intercostal recession? These are very, very important signs. They'll be worth just sticking an eye out in A&E or any pediatric ward to learn to pick up on these signs and see what they really look like when you're looking at a real child, or maybe have a look on YouTube for a video. But they're very useful signs to assess respiratory distress. Accessory muscle use you'll mostly see in older children. In sort of infants, you'll tend to see nose flaring and intercostal recession. And then obviously you're looking out for things like stridor and wheeze, any change in color, are they really sweaty, and do they look drowsy? They're not their normal self to the parents. So this is a traffic light system that I mentioned, that it'll be important. I mean, no one would expect you to learn this by heart, but the main part that you should really be aware of is the high risk category. Often the high risk does tend to come up in exams, and so it is worth just knowing what are the red flags in children. And they're divided in five categories. So what you're looking at is their color, their activity. Respiratory has a whole section just for itself, and circulation, hydration, and any other signs. Obviously, things like being pale, mottled, and ashen that will jump at you instantly is pretty significant red flags. But also things to bear in mind are tachypnea. There's different levels between amber and red risk. Sometimes that comes up in exams. And then the other one to look out for is temperature, especially in younger children. So under 3 months old, temperature above 38 is significant and is a red flag. So just bear in mind, I'm not going to go into all of these, but they are worth remembering and learning to an extent. Now, so we've got a little wheezy boy, and wheeze is extremely common in children. I'm sure if any of you has had a pediatrics rotation, you would have come across this, especially around this time of the year. In fact, 1 in 2 children will wheeze by the time they're 6-year-old, and it is mostly associated with viral upper respiratory tract infections. So you're boxed under colds, things like RSV, coronavirus, the old type, not the new type, but also with the new type, metapneumovirus and parainfluenza, the whole lot. Now, bear in mind that if children are wheezing around the time of birth, that's not normal, and it's more suggestive of structural abnormalities. They will often need ENT review, anything like that. But when it comes to viral wheezing, there's some risk factors which include atopy, prematurity, and exposure to smoke, which a lot of parents don't realize, and it's always worth having a conversation about smoking cessation with parents, in general, but also parents of wheezy children. So the classification that's used at the moment is the European Respiratory Society classification for preschool wheeze. And it's mostly divided, this has changed over time, but at the moment it tends to divide it between episodic viral wheeze and multiple trigger wheeze. The episodic viral wheeze is your classical sort of benign viral wheeze, where a child will have wheezing episodes when they have a cold, but they'll be symptoms free in between. Now, this is not a strict category. Patients can move from one to the other, so it is always worth taking a good history. But this will be sort of your more simple, less complex wheeze, and what it used to be called, and it can be transient. And often these children won't go into having problems later in life. On the other hand, multiple trigger wheeze, when children will wheeze with upper respiratory tract infections, but then also might have other episodes in between, which can be triggered by allergens, then these children tend to be at higher risk of having asthma later in life, and they will often have more severe episodes of wheezing. So do bear in mind that even if a child has episodic wheeze, they always are at small risk of asthma. If they have multiple trigger wheeze, then they're at higher risk than children with episodic wheeze. But children that tend to have risk factors for persistence in, school age, because we're talking about sort of preschool wheeze, when straightforward, will tend to have risk factors including having allergies before the age of 3, having had wheezing in the first 3 years of life, which is often RSV and rhinovirus associated, a family history of asthma, atopy themselves. These children will often have eczema, and multiple trigger wheeze is a risk factor. Now, for all wheezy children, the management is a trial of salbutamol. You can step up to intermittent montelukast if they have lots of wheezing, but that tends to be sort of guided by tertiary centres, or at least pediatrician rather than GP level. But salbutamol will be a first good start for all children until you have any suspicion that this might be asthma, and then you might want to escalate to steroids. But we do tend to avoid steroids in very young children if it's just viral wheeze, because obviously they come with lots of other problems and side effects. We don't want to give steroids to children that don't need them. Now, a very brief word on asthma, because there is a whole lecture series on asthma in children already with Quesmed. So I'm just going to, cover it because it is important and we've kind of touched upon it. So in terms of, 4 exams, written, oral, it is always very useful to have a quick definition of asthma, because this stuff comes up all the time. And the main components that you're looking for in an answer on what is asthma should include a variation on, it's a chronic airway disorder, which is characterized by reversible obstruction. Your reversible is obviously a key word, which is because of abnormal inflammation, so an abnormal inflammatory response of the airway, and bronchial hyperresponsiveness. So these 3 things that I've highlighted in this definition, always worth bearing in mind when it comes to asthma. And it is the most common chronic medical condition in children, associated with things that we've kind of mentioned for wheezing as well, but in particular, a history of atopy, which is either personal history or family history. And children that are in urban environments tend to have high risk of asthma, tobacco smoke, and premature children as well. Now, when it comes to diagnosis and defining asthma, what we're looking for is more than one of wheeze, breathlessness, chest tightness, and cough. So just wheeze per se is not enough to diagnose asthma. These children often have other symptoms. And then when you're taking a history, things you'll be looking out for is there a trigger for episodes of wheeze, which is not viral? Is there a trigger for their cough or shortness of breath? And symptoms with asthma tend to be worse at night or early morning. And, if you give them a trial of bronchodilators of salbutamol, they tend to get better. Now, in terms of diagnosing, like I mentioned, our objective tests are usually reserved for children above 5 years, just because anyone younger would really struggle to follow commands for spirometry or peak expiratory flow. So we often treat children under 5 as asthma and then work them up for diagnosis later. Other things that you'd be doing, in older children, obviously spirometry, you'll be looking for bronchodilator reversibility on spirometry, and the FeNO, which is a fractionally exhaled concentration of nitric oxide, which is a very good marker for sort of eosinophilic inflammation of the lungs, and a higher level of FeNO tends to correlate quite well with asthma and response to steroids. Now, when it comes to management of asthma, NICE and BTS can never agree, but apparently they're now working on a guideline together. So keep your eyes peeled. I think it's coming up early next year. But you will have heard more or less of the stepwise approach and management to asthma, which is, stepwise in terms of medication, but also very focused on trigger avoidance and good education. Asthma nurses tend to be very involved in children with asthma. They will provide them, a clear plan, which is often also followed at school, and children will have to have their inhaler technique reviewed quite regularly. But remember also, younger children will always have a spacer, and we'd start with MDIs and then remove the spacer as they get older. But spacers are great in adults too, so if you like a spacer, keep using it. All right, let's move on to question 2. This is a little bit more of your box standard early years medical school question, but I'll give you a second to read. Okay, have we got enough answers to show the poll? Great, well done. Yes, chromosome 7. You still remember from your early years of medical school. Yes, so what we're looking at really is likely to be cystic fibrosis, and so the recurrent chest infection and failure to thrive, markers. So really briefly talking about cystic fibrosis, which is somewhat recessive, and it is the most common single genetic condition in the UK, which affects the cystic fibrosis transmembrane regulating protein on chromosome 7. There's loads of mutations. The most common, which sometimes pops up in exams, and one of those bonus points, is a delta F508, if you can remember that. And, as you might know, it does significantly reduces life expectancy of patients, even though now it's getting a lot longer and we do have much better treatments. It is still a significant, a significant condition for patients' lives. So the way we tend to pick it up is on newborn blood spot screening, which has been introduced in 2007, and it's usually done on day 5. And what the blood spot screening looks at is actually immunoreactive trypsinogen, which is worth knowing again for one of those brownie points in exams. But it's actually a pancreatic produced protein, which correlates well with CF, both in patients who have overt pancreatic insufficiency and the ones that don't, interestingly enough. And then if that's high, then children's blood are sent for genetic screening. But we don't pick it up in all children, and sometimes we have to do sweat tests when they're older. And CF phenotypes are incredibly variable. They can be very unpredictable. But then the key sort of pathological issue are the viscid and sticky secretions in the tubular structures, so the lungs, sinuses, the liver, the pancreas. And that's all because of failure of transporting the chloride and sodium, across the channel, which results in abnormal secretions. So the most common things you will see are recurrent chest infections and failure to thrive. But a very high proportion of patients will have pancreatic insufficiency, and often it is picked up before the respiratory symptoms. Other things that you will need to know about for exams are patients presenting with meconium ileus, pancreatitis, type 1 diabetes a little bit later in life, and periportal liver cirrhosis. These are all quite common. So the main issue with cystic fibrosis and what really shortens life is that having these very thick secretions is a great environment for bugs to grow. So the main ones that we tend to see in these patients are, Staph aureus, which we try and tend to delay as far as possible by giving prophylactic antibiotics, but it's not always possible. Pseudomonas you would have heard of. It's the lovely sticky bugs that sticks to everything, and Haemophilus influenza is another one. But these children also tend to grow all those weird and wondrous bugs that you only see, once in your lifetime, like Burkholderia capacia, I don't even know how to say that, Skinotrophomonas, and Aspergillus. That's quite common, it tends to be treated with longer courses of antibiotics. And when you look at what's growing in these children's sputum, you start to really understand why it's important to keep these children apart from each other, which is very sad, actually. They can't share how they manage their conditions in person, at least, because the passage of one of these bugs from one child to the other can prove fatal, and it is important to keep them, try and minimize swapping bugs. So when it comes to treatment of CF, what you'll be looking at, the key word really is multidisciplinary team, because it's a whole body system. And it will require not just doctors' input, but lots of other healthcare professionals. There'll be lots of MDT teams happening, and often these children are managed at certain centres. Not all specialist respiratory centres will manage children with cystic fibrosis because they do need such a big input. Things in particular that you really shouldn't forget are physiotherapy. Very important for these children to have it twice a day. We'll often give them prophylactic antibiotics. You will be treating the first Pseudomonas infection quite aggressively to try and eradicate it if possible. And other things, mucolytics, hypertonic saline DNAs are all used in these children to loosen up their secretions and make physiotherapy more effective. And then things like replacement of pancreatic enzyme, creon. If they have diabetes, they will need management for diabetes. And then there's all these new drugs coming up now, which are sort of more genetic therapy, and they will replace the function of the CFTR protein. And they're quite exciting, so lemacaftor, vacaftor. And then obviously lung transplant is, the mainstay of treatment. Well, not really, but it's what everyone would hope to get. But a lot of these patients, might not make it to getting a lung transplant, really, and you need to be fit enough and big enough, and there needs to be enough availability of organs, of course. All right, move on to question 3. And for this one, I think I've got, there we go, the reference ranges. You can have a look. Okay, shall we bring up the poll? Have we got enough answers now? Sorry, I'm just conscious of time because we have so much to cover. Very well done. Okay, so let's close this up. There we go. Yes, oral dexamethasone. So most of you would have picked up that this child is likely to have croup. So we have a 2-year-old, so they're nicely sitting in the age range for croup with a harsh cough, and the funny noise is probably a little bit of stridor, which is happening at rest. So that starts making us worry that this child might need to come into hospital. However, he's alert and his observations are pretty good. Now, when it comes to croup, all children will get dexamethasone, so worth remembering. So the actual name for croup is viral laryngotracheobronchitis. Sometimes you will see this in exams as like a little bit of, trying to confuse you guys, but remember that is the full name of croup, and tends to affect children between 6 months old and 3 years old. Now, the traditional time that children are affected is autumn and spring. It tends to be particularly in spring, but things are changing now in COVID times. We see these children all year round, but do bear in mind that tends to be what used to be in exams, and it's caused mainly by para-influenza virus. That's the other keyword for exams. But other viruses can cause croup. It's just a lot less common. So RSV and adenovirus. Now, the key symptoms that you'll see in patients with croup are a hoarse voice, a barking cough, and a harsh stridor. Very harsh words, isn't it? So, but barking cough tends to be sort of the key one that makes people think, oh, this might be croup. And they will often have cough and have symptoms for 3 to 7 days, but it can last for a lot longer. And often these children will be well enough that they don't need to be in hospital. But we use the Western clinical scoring system to score the severity of croup and decide which children can be treated at home and which children need to be in hospital and have repeated courses of steroids. So these are the main things you'll be looking at. You don't need to learn this by heart by any means, but just to be aware that this is available. And we'll be assessing the level of stridor, recession, cyanosis, level of consciousness, and air entry. Now, if a child has mild croup, then actually all of children with croup will get dexamethasone. If it's mild croup, they will just get 1 dose and they can be managed at home. But anything above moderate, so moderate and severe, should be treated in hospital. And these children will often have they'll have a dose of dexamethasone in the community before coming to hospital, and then they'll have a repeat dose in hospital and then be assessed whether they need any further steroids. But bear in mind, the children that you need to be admitted in hospital, like I mentioned, are the ones that have any moderate or severe croup. If they have had a history of previously severe croup or severe obstruction, they already have abnormal anatomy, abnormal respiratory system. If they're younger than 6 months, if they're immunocompromised, or for other issues, they just can't feed well enough, so you're worried about fluids, or the diagnosis is not quite certain. And also, if parents are very anxious, that is something nice about pediatrics. We do think about families, and it's important, to keep into account their level of anxiety. And remember, when it comes to managing croup, very important to keep the child calm to avoid them going into coughing fits and, worsening their stridor. You can manage their temperatures with paracetamol and ibuprofen, make sure they're having enough fluids. And steroids really are the mainstay of treatment. Sometimes nebulized adrenaline can be given if needed. I haven't seen it very often. And for these children, we wouldn't give antibiotics, if we think this really is croup and they don't need them. Now, this is your exclamation mark, bacterial tracheitis, which tends to be one of those potential differentials that comes up in exam. And it's always worth bearing in mind the difference between croup and bacterial tracheitis. So bacterial tracheitis is a rare complication of upper respiratory tract infections, but it can happen after croup, if you have bacterial superinfection, because it tends to usually happen with Staphylococcus aureus. And what you will see in these children, they will have stridor, but they will look very sick. So this is when we talk about a toxic looking child. and they'll often have a high fever. And the history will often go that the child had a virus, was fine, was getting a bit better, and then suddenly got a lot worse. And that's when we start thinking about bacterial superinfection or viral infection. It tends to progress really rapidly. You need to manage these children pretty quickly. And often, they will not respond to adrenaline or the other management that you do for Croup. For these children, you need to be thinking airway. So, make sure that you've called anesthetics and ENT in case you need an emergency airway, and secure the airway, because, the inflammation can obstruct the airway, and then once it's gone, it's gone. So, once you spot this, get the other teams involved. Okay, question 4. Let's talk a bit more about stridor. Oh, sorry, and the reference ranges are up there. Good. Well done. So most people picked out that really this is a patient for ENT. So this is a third, classical stridor differential in exams, and the other one you really don't want to miss. So quite typically, you'll have a patient that's come from abroad, or perhaps it hasn't been fully immunized. It comes with stridor. They're pulling the tongue out. They can't answer your questions. They have a fever. And what you really should be thinking here is that this is epiglottitis. So it is very rare in the UK nowadays. The hip vaccine has been made routine since 1992, although it's been available since the 80s, but it just wasn't in the program. And the key symptoms you'll have in these children are dyspnea, so they're short of breath. You kind of call it the 4Ds, but dyspnea, dysphagia, drooling, and dysphonia. So they'll be making all these sounds. And stridor really is quite a late sign, because it means you're losing the airway, if you start getting stridor. So, hope that you never get stridor in these children when you see them, because at that point you really should be, fast bleeping ENT and anesthetics to come have a look. Now, the one key thing that will always come up in exams is do not examine the throat, because by examining the throat, you can upset the child and you can actually, worsen the swelling and lose the airway. So if you're suspecting epiglottitis, just don't have a look. And there's sort of this X-ray, which you probably won't see very often, but what you might see in patients with epiglottitis is a thumbprinting. This sort of thumbprinting sign on X-ray. Again, this one of those exam things, really. In terms of management, until you've got ENT anesthetics, you'll be doing supportive treatment. So give them IV antibiotics, oxygen, nebulized adrenaline, and make sure these children are ill by mouth, because they might need emergency treatment, surgery. Now, a very, very brief word on foreign bodies, because that's the last, things you might get, especially in A&E, if a child is coming with stridor who's otherwise quite well, and these children will often not have a fever. The stridor would be sudden, it's kind of a history, and it tends to be in children between 1 to 2 years old, although I have seen children much older swallowing things and inhaling things that you wouldn't think they do at their age, but it does happen, especially when they have younger siblings. But yeah, at least at the beginning, these children won't have a fever unless the foreign body's been there for quite a while. And what you'll be doing is getting a chest X-ray, see where the foreign body is, And if it's in the airway, then they probably will need a bronchoscopy to fish it out. And bear in mind that the reason why it's so common in children is not just because they stick stuff up their nose, but they also have large heads compared to their body size and large tongues. The trachea is a lot shorter, so it is a lot easier for their airways to occlude and get stridor once they've inhaled something. Yeah, so a very brief summary on the main three, apart from foreign body, the main three causes of stridor that, at least infective causes of stridor that you should bear in mind. And it is worth getting these around in your head because they do come up in exams. So the difference between Croup, bacterial tracheitis, and epiglottitis. And what you're looking at is sort of Croup. You have an onset of days, there's classical history with a barking cough, they'll have a fever, but it won't be that high. They can be unwell, children, but not as unwell as the ones with bacterial tracheitis and epiglottitis, who will often be toxic and very ill, have a high temperature. In epiglottitis in particular, you often will not have a cough, and the child might be drooling, which you're unlikely to see with children with Croup or bacterial tracheitis. And then the causative organism as well is worth bearing in mind. So Croup tends to be viral, bacterial tracheitis is Staph aureus, and epiglottitis is typically Hib, so Haemophilus influenza B. Although other things can cause epiglottitis, but it's a lot rarer. So there we go. Question 5. Great, so the vast majority answers Streptococcus pneumonia and picks up rightly that this is the most common cause of pneumonia in children. So this child is 6 years old with cough and breathlessness, they have reduced breath sounds with dull percussion. It all starts pointing towards strep pneumonia. And pneumonia is really quite common in children. And in fact, outside the UK, I mean, even within the UK, but outside the UK is one of the main killers of children. Children are very susceptible to pneumonias, and up to 45% could be viral rather than bacterial, although we do treat all children with antibiotics when pneumonia is suspected. And they'll have, what you'd expect to see in a child with pneumonia. They'll have a fever, they might be coughing, shortness of breath, respiratory distress, and you might hear crackles. The younger the children, the less you might see some of these classical signs and symptoms, but you will probably get an X-ray and it'll become quite obvious at that point. So the most common bacterial cause of pneumonia in the UK is strep pneumonia. Then there's a weird and wondrous ones. I'm not sure how relevant this is for you guys, but sometimes in older children, if they're wheezing and they have extrapulmonary signs, that might be mycoplasma pneumonia. And then children who tend to have very severe disease with quite rapid progression and empyema will likely have Staph aureus, which tends to form these horrible cavitating lesions in the lungs and bullae. But strep pneumonia can cause empyema and can be a very nasty infection. So for these children, you will need to have a look at your red flags and admit them if there are any worries, and make sure they have a good course of antibiotics. So question 6. How are we doing for answers? Yeah, great. So like, oh, I feel like the room is divided on this one. Okay, so this is, I mean, I don't know how relevant it is nowadays, but it does tend to be a favorite of exams. We have a child that has had a cough for 4 weeks. I mean, that's quite a long time. But the mum is giving this history of the child being quite snotty, and then, progressively having increasing bouts of cough. And then the key word here really is cough with gasps for air in between. They're having these bouts of cough with gasps of air. So really what we're looking at here likely is pertussis, or whooping cough. And because a child has had the cough for 4 weeks, they can be managed at home with paracetamol. Now, whooping cough caused by Bordetella pertussis is, a notifiable disease, which gives you an idea that it is a fair bit rarer nowadays than it used to be. But, with the advent of people who don't like vaccines, it's starting to become a little bit more common. And pregnant women are often offered a vaccine in pregnancy, but, they can always decline it. And that's because whooping cough is particularly dangerous for neonates. It can make them really quite unwell. And the 3 main phases of whooping cough are sort of what Mum was describing in the case from the previous question, a catarrhal phase, which usually lasts 1 to 2 weeks, when children will have some more of like coryzal symptoms, the rhinitis, being irritable with a fever. And then they'll start having this phase when they have paroxysmal bouts of coughing, which can last 2 to 8 weeks. And the classic, whooping sound that you get is when children have severe paroxysmal coughs, which can make them vomit. It can blow capillaries around their eyes. It can be really quite severe when they don't take a breath in between. And then up to 3 months, they have this convalescent stage when they're not quite themselves, but the cough is subsiding and they get a little better. So I hope this works. I've got a little sound clip to make you guys. There we go. This is what a whoop sounds like. Oh, poor baby. So hopefully you get impressions of that's, whoop sound in between coughing is why it's called whooping cough. And the thing with whooping cough is treatment really is mainly supportive. There's not that much we can do. If a child has been coughing for less than 21 days, then NICE recommends prescribing a macrolide antibiotic, which can reduce the period of infectivity. So it's more to stop spread of whooping cough, but it doesn't actually make that huge difference for the child. So it doesn't change the clinical course. I remember it's a notifiable disease, so we should make, the local public health authority know. And it is important to advise parents of these children that children can cough for a very long period of time. So they might be coughing up to 3 months, but them coughing for that long is not a reason to keep them from school. They should stay away from school if they haven't had any antibiotics and they've been coughing for, up to 21 days, they should stay at home. But after 21 days, they can return to school, unless obviously they've had antibiotics for 5 days, in which case afterwards they can go back. And now, like I mentioned, especially neonates and children under 6 months can be very poorly with whooping cough. So we should be admitting them if they're under 6 months old. And then any other children, if there are significant breathing or feeding difficulties, especially when children are coughing so much they can't feed, it's worth bearing in mind that can be significant. And then children can have complications, including pneumonia, like I mentioned, so a bacterial superinfection after, or seizures. Okay, so question 7. All right, well done. Yeah, so the key to this question, to the answer to this question, really goes back to picking out those red flags in these children. So I'm guessing most of you would have picked out this 18 months old is likely to have bronchiolitis, have scattered crackles, history of having a bit of a cold and wheezing and some difficulty feeding. But really the key here is that they have nasal flaring and these nasal inspiratory sounds, which are actually the full name for grunting. So if a child is grunting, then we should be admitting them into hospital and making sure they have supplemental oxygen, even though it doesn't look like they cyanosis, we should be taking observations on these children. So bronchiolitis, another one of the really important respiratory diagnoses, bread and butter for any pediatrician, tends to affect children under 2 years of age. Again, the typical time of the year is winter and spring. It's autumn at the moment, and we're seeing lots of bronchiolitis, but they say this is a particularly odd year. But for exams purposes, this often tends to be, the winter and spring malady. And the key culprit is respiratory syncytial virus, so RSV, which causes this wheezing, cough, and fever, and typically fine inspiratory crackles in susceptible children. Now, in order to protect the more vulnerable children, which tends to be the one that have either the premature, ex-premature children, chronic respiratory disease, or chronic heart disease, cardiac patients, and these patients will receive palivizumab, which is a monoclonal antibody against RSV, which is given during the RSV season, every 30 days. And, it really does help these children, although it's not foolproof. And when it comes to bronchiolitis, it really is all about supportive management. So all other medication like steroids, bronchodilators, antibiotics will not cut it. What we do is just sort of provide oxygen support and look for respiratory failure, basically. So we'll score bronchiolitis based on clinical severity. Mild bronchiolitis, these are worth knowing. Really, this kind of stuff does come up a bit in exams, and it's things like look at their feeding. If they're feeding well, they're not distressed, there's no risk factors, and these children can be managed at home. However, if there's any poor feeding, the work of breathing is high, there are risk factors, or the oxygen is low, and these children will need to have at least A&E assessment and maybe stay in overnight just for a little bit of oxygen, some feeding support. And if not, might have, need a longer hospital admission. And obviously severe, then these children can get really quite sick, and they should be managed in HDU, with ventilation, heavy fluids, have capillary gases and things like that, and sometimes might need CPAP. I think they should say CPAP rather than CAP. What you're looking for is things like worsening respiratory distress and dehydration. So the management of bronchiolitis, it tends to be, it does come up in exams and it changes all the time. I'm not quite sure why. So there's been a recently released guideline with slightly changes in the saturations, target saturations for these children, so worth bearing in mind. But we will be admitting these children if there are any episodes of apnea, if the child looks really unwell, and then if there are any signs of severe respiratory distress, things like grunting, recession, elevated respiratory rate, sort of like a little child that looked well enough at the beginning, but children can look well for a very long time and then crash quite quickly, so it's worth picking out these signs. Central cyanosis, and then the new target saturations are that if a child is under 6 weeks old, we admit them if their SATs are under 92%, and if they're over 6 weeks old, then if the SATs are not below 90%, that's when they should be admitted. And that should also guide oxygen supplementation, so these new targets. You would have heard probably of NG feeding and giving NG tube to these children only if there is inadequate oral intake, or if there's lots of respiratory distress. If we are going down the CPAP route, then NG feeding is worth considering if there's lots of hypoxia, but it's a little bit higher level. But for exam purposes, medical school, I would say if there's inadequate oral intake, that's when you go for NG. And sometimes these children can need higher level of respiratory support, such as CPAP or BiPAP. And that will be determined by the degree of respiratory distress, and you will need a capillary gas basically to see whether there is any respiratory failure, you know, are the CO2 rising and things like that. So this is another real short summary to compare croup and bronchiolitis, which tends to be another one that people sometimes get a bit confused on. So with croup, we're looking at slightly older children sometimes, so 6 months to 3 years. Bronchiolitis tends to be the younger children, so under 2 years old, are the most vulnerable. Supposedly the time of the year at which these diseases go around are slightly different. So autumn and spring for croup and winter and spring for bronchiolitis. Again, this is a bit more for exam purposes. And then the symptoms that we've discussed, a little bit different. Croup tends to be an upper airway disease, while bronchiolitis is a lower airway disease. So you'll hear crackles and things like that. They're both caused by viruses, but croup is parainfluenza mainly, and bronchiolitis respiratory syncytial virus. This is another one of those exam favorites. And then, you know, supportive treatment mainly for bronchiolitis, while we are going with the big guns and giving steroids to children with croup because of their upper airway involvement. Okay, so almost there. So question 8. I think I've got, yes, reference ranges. Sorry, they kind of go on top of the question. I'll bring them up in a second. Okay, how are we doing for answers? So I mentioned I'll be very briefly touching upon you know, presentations, first presentations in newborn. But the reason why I thought it would be helpful to include something like this is because it does tend to catch people out. So this is actually more in keeping with transient tachypnea of the newborn. And the clue is all in the question, so always remember to read well. So this is a child that's born by a C-section, a term, so 37 plus 2, this is a term birth, and it starts becoming increasingly breathless 2 hours after delivery. And out of all the observations, the main thing is that they are hypoxic. This is quite typical of transient tachypnea of the newborn, which presents usually within 4 hours from delivery and lasts under 72. And the main things that might come up in exams, and the main things to remember is that it is associated with C-section. Other risk factors include maternal diabetes and prematurity, but it can happen in term babies versus, you know, respiratory distress syndrome, which tends to be a lot more with premature babies. And it is all because of retained fluid in the lungs. You know, the child is not squeezed out of their mother, so the fluid tends to stay in the lung, and they can have this, you know, TTN. The main treatment is usually supplemental oxygen. Sometimes children might need CPAP just to open up the airways and push, you know, the fluid out, but it tends to resolve, you know, definitely within 72 hours and usually within 24 hours by itself. So other causes of shortness of breath in neonates, like I mentioned, just one slide, because this is mainly pediatrics, but just to bear in mind in case these do come up. We've talked about TTN. The other big one that I'm sure you will all learnt about is respiratory distress syndrome, which tends to affect mainly children under 32 weeks of gestation. And that's because that's when the lungs are most premature. You know, they're really not very fully formed before 32 weeks. And the way we tend to prevent this is by giving 2 doses of corticosteroids to mum to complete the full prenatal course, which tend to be 12 hours apart. Other presentations, meconium, aspiration. These children can be very poorly and might really not do very well if they have, had meconium aspiration. They can be quite limp at birth. Soon after birth, they often tend to be post-term. That's when meconium is more likely to be passed and floating about in the amniotic fluid. And another one, which is one to bear in mind, is pneumothorax, which can happen in 2% of term infants, and it is life-threatening if it's tension pneumothorax in particular. So we're at last question now. Almost done. Okay, shall we have a look? Well done. So most people picked out this slightly rogue presentation. Might be, we might find a culprit by giving the child the trial of an alginate. So I wanted to include a bit of a rogue presentation of GORD, and that's because I want you guys to think that sometimes things that are not respiratory may present as a respiratory issue, and actually gastroesophageal reflux is very common and is often mistaken for things like asthma, although it can coexist with asthma, but it can give all sorts of respiratory problems, including coughing, wheezing, and it is worth to exclude it in children who present with typical symptoms. And if you have reflux that is repeated and severe enough to cause harm, then we call it GORD. And these children may have, a variety of symptoms, and we'll first trial a bit of treatment, maybe an alginate, sometimes a PPI, so we'll give omeprazole, and then investigate these children later on, if you think there might be something else going on. And the mainstay of treatments are positioning, so keep the child upright after a feed, and you can give them some thickeners and frequent smaller feeds, and then management with drugs, like I mentioned. And this is incredibly common. If you ever work in pediatrics, you will see lots and lots of children with reflux coming into A&E and CAU, and it is worth keeping an eye out for this. So, as a little summary of what we've covered today, we've talked about these main presentations in peds. So wheezing, remember common things when children wheeze are asthma, CF, cystic fibrosis, children can wheeze, bronchiolitis, and then things like GORD. Stridor is another big one for your exams. Remember things like foreign bodies, Croup, Epiglottitis, bacterial tracheitis, and congenital obstruction if they're born with stridor, although we haven't really touched upon it today because that's more ENT. Coughing can be acute or chronic. If it's acute, we're thinking about our box standard infections, and chronic, remember pertussis amongst your chronic cough, especially in times of Novax, and things like GORD and asthma. And finally, breathlessness, which again comes with infection, but then also asthma. And then there's a few very specific newborn presentations of breathlessness, which might be worth bearing in mind. All right, so if you guys want to do any more reading on peds respiratory, this is a few resources. And I'll just have a wee look at the questions, if there's anything that we can answer. You always ask about slides available at the end. I'm afraid I do not know how that works, guys, but I think this does go on YouTube, and the recording will be available for Quesmed, yes.
Thank you for that lovely session. I think there are a few questions, one or two questions in the Q&A.
Yeah.
But in terms of recordings, I don't think we send out the PowerPoints, but the recordings will be all posted onto the Quesmed tutorial YouTube channel, which is free to access for anyone.
Yeah, exactly.